This presentation is about meningitis. Meningitis is acute inflammation of the brain and spinal cord. There are three main types: bacterial, viral, and fungal. For most of the presentation, we're going to focus on bacterial and viral. Bacterial meningitis is also known as acute meningitis. It's less common but more serious. Babies are at the highest risk. Viral meningitis is also known as subacute meningitis. It's more common but less serious. Kids older than 5 and those with weak immune systems are at the most risk. Fungal meningitis is also known as chronic meningitis. It's rare and very serious. It's usually in immunocompromised patients, such as those with HIV.
In bacterial meningitis, there is an inflammatory response in the subarachnoid space of the spine. The infection is in the subarachnoid space, therefore it travels through in the cerebrospinal fluid throughout the whole central nervous system. The body will create more cerebrospinal fluid and produce purulent secretions that mix with the cerebrospinal fluid, which is circulated, causing the infection to spread to the cranial nerves, brain, and spinal cord. The infection that is circulated will cause an inflammatory response, and the increased cerebrospinal fluid leads to cerebral edema and swelling. That will lead to increased intracranial pressure. If the increased intracranial pressure and cerebral edema is prolonged, the patient could get brain damage and residual neurologic dysfunction. Viral meningitis is self-limiting, meaning it will run its course and the healthcare team will just treat the symptoms. Full recovery from viral meningitis is expected. The patient will still experience an inflammatory response in the CNS and increased intracranial pressure due to the increased cerebrospinal fluid production, but there's no purulent drainage. The patient is at risk for neurologic damage due to prolonged cerebral edema. However, as I said, it is self-limiting and recovery is expected. These organisms are the leading causes of bacterial meningitis. Vaccines have dramatically decreased the incidence of Haemophilus influenzae causing bacterial meningitis. When a person gets meningitis, it can enter the body through multiple ways. One way is the upper respiratory tract, like the nose, where the organism can multiply and enter the bloodstream, or just enters the bloodstream directly through a break in the skin or a break in the skull where bacteria can directly and easily enter the cerebrospinal fluid. Viral meningitis is caused by enteroviruses, HIV, or herpes that usually gains access to the body through respiratory droplets of an immunocompromised person. The respiratory droplets are spread from person to person, and the infection grows and enters the cerebrospinal fluid from the upper respiratory tract.
Clinical manifestations of meningitis include fever, a severe headache that often becomes worse with time. This may be accompanied by nausea and vomiting. Patient may experience nuchal rigidity, which is neck stiffness. They may also have photophobia, or an increased sensitivity to light. A patient may experience a decreased level of consciousness, and a skin rash may be present, especially if the microorganism that has caused the meningitis is meningococcus. And the patient may also have petechiae on their trunk, their extremities, and their mucous membranes. A seizure may occur in 1/3 of all meningitis cases, and less commonly in about 5 to 10% of cases, patients will be in a coma, and this is associated with a poor prognosis.
The diagnostic tests for meningitis include CT scan, blood cultures, and a lumbar puncture, which is also known as a spinal tap. A CT is to rule out the obstruction of the foramen magnum in order to prevent fluid shifts resulting in herniation. Blood cultures are done to determine which organism, if any, are causing the symptoms so they can be treated with proper medications. We're also checking protein, blood count, and glucose in the blood. The lumbar puncture is done to check for organism causing the symptoms, protein levels, glucose levels, and white blood cells. The predominant white blood cells in meningitis patients are neutrophils.
When meningitis is suspected, a sample of cerebral spinal fluid may be collected, and the fluid will be tested for different things such as white blood cell count. Typically, the white blood cell count in the cerebral spinal fluid is 0 to 5 cells. If there's bacterial meningitis present, you'll see an increase in white blood cells, and it may be over 1,000. In viral meningitis, it's also increased, but it's typically between 25 and 500. Protein in the cerebral spinal fluid is normally between 15 and 45 milligrams per deciliter. In bacterial meningitis cases, you will see an increase in protein, typically above 500 milligrams per deciliter. In viral meningitis, it was also increased between 50 and 500 milligrams per deciliter. Glucose in the cerebral spinal fluid is normally between 40 and 70 milligrams per deciliter. With bacterial meningitis, it's typically decreased, so it will be between 5 and 40 milligrams per deciliter. For viral meningitis, it can be normal or can be low, but it's typically still above 40. The cerebral spinal fluid will also be assessed for appearance, and with the presence of bacterial meningitis, the appearance of the cerebral spinal fluid may be turbid or cloudy, and with viral meningitis, it may be clear or cloudy.
Some medications that are used are IV antibiotics. They are started immediately, even while tests are being done to determine if the meningitis is bacterial or viral, because antibiotics can be stopped if it is viral, and immediate treatment is important if it is bacterial. Narcotics like codeine are used for headache and pain. Corticosteroids are used to reduce inflammation in the brain and prevent seizures. Antipyretics like acetaminophen are used to treat elevated temperatures. Phenytoin is used for seizure prevention, and diuretics like mannitol are used to pull excess fluids from the brain, reducing the intracranial pressure and causing an increase in urine production. Increased intracranial pressure is the most common complication. It is due to an increased production of cerebrospinal fluid and inflammation in the meninges. It also causes an alteration in mental status. Residual neurologic dysfunction is another complication. It involves many different cranial nerves, but it usually disappears within a few weeks. Intracranial pressure compresses the optic nerve and can lead to papilledema. This is inflammation of the optic nerve. This causes visual disturbances, headache, and vomiting. Blindness can also occur. When the oculomotor nerve, the trochlear nerve, and the abducens nerve are involved, it affects ocular movements. It can also cause ptosis, which is drooping of the upper eyelid, and diplopia, which is double vision. When the trigeminal nerve is involved, it causes loss of the corneal reflex. This is the blinking reflex. When the facial nerve is involved, it causes facial paresis. This is loss of facial movements or paralysis. Facial muscles might droop or just become weak, and this can be bilateral or unilateral. Last, when the vestibulocochlear nerve is involved, it affects the ear, causing tinnitus, vertigo, and deafness, which can be permanent with bacterial meningitis. Other complications are hemiparesis, dysphagia, hemianopsia, acute cerebral edema, headache, non-communicating hydrocephalus, and Waterhouse-Friderichsen syndrome. Hemiparesis is weakness or paralysis of one side of the body. Dysphagia is an impairment in communication. This can affect verbal and written communication, or it can affect comprehension of communication. Hemianopsia is loss of half of the visual field. Acute cerebral edema from meningitis can cause seizures, oculomotor palsy, bradycardia, hypertensive coma, and even death. Headache can be an ongoing complication that lasts for months until the inflammation has completely resolved. Non-communicating hydrocephalus is a buildup of fluids in the brain, where cerebrospinal fluid is blocked and not able to flow from ventricle to ventricle. Reabsorption by the arachnoid villi may also be obstructed by exudate. This requires surgical implantation of a shunt. Finally, Waterhouse-Friderichsen syndrome is a complication of bacterial meningitis. Clinical manifestations are petechiae, disseminated intravascular coagulation or DIC, adrenal hemorrhage, and circulatory collapse. DIC is a blood clotting disorder in which clots form inside the blood vessels using up clotting factors. This can lead to massive bleeding in other areas. This and shock are the most serious complications and are associated with meningococcemia. This is a bacterial infection like meningitis, but it stays in the blood instead of entering the central nervous system.
We already mentioned the most common side effect of meningitis being increased intracranial pressure. Preventing or decreasing increased intracranial pressure is still being studied because it increases the rate of survival of patients with bacterial meningitis. Thus far, doctors focus on using antimicrobial and anti-inflammatory agents to decrease the swelling associated with the inflammatory response. Now I'll go over the signs and symptoms and how to prevent the complications that were on the previous slide. Hemiparesis, dysphagia, and hemianopsia can lead to one-sided weakness, difficulty remembering words and expressing thoughts, and bumping into things due to not noticing objects on one side. It can be prevented with decreased intracranial pressure and fluid control. Acute cerebral edema can lead to convulsions, double vision, droopy eyelids, and severe hypertension. These can be prevented with fluid control, anticonvulsants, and corticosteroids. Non-communicating hydrocephalus can lead to headache, vomiting, nausea, papilledema, vertigo, memory loss, urinary incontinence, and poor coordination. These signs and symptoms can be prevented in childhood with a meningitis vaccination. Finally, Waterhouse-Friderichsen syndrome can lead to fever, chills, headache, joint and muscle pain, and vomiting. A vaccination is available for prevention if it is caused by meningococcal bacteria. The two common themes for prevention are vaccinations and keeping intracranial pressure low through fluid control and medications. There is a team of people that are involved with the treatment of meningitis. Pediatricians play a crucial role on this team because meningitis mostly affects children and babies. Family med docs work with adult patients and are the ones who help keep signs and symptoms under control. ER docs are crucial because meningitis can be a medical emergency. They can diagnose and begin treatment before it's too late. Neurologists help interpret the lumbar puncture to make sure that you have meningitis. The last thing anyone wants is to get treated for something they don't have. Pharmacists are medication specialists. They can help adjust medication types and doses. Other team members include, but are not limited to, nurses, blood draw techs, and radiology techs. Some of the nursing diagnoses for meningitis include acute pain related to biological injury, excess fluid volume related to increased intracranial pressure, impaired mobility related to central nervous system insult, impaired comfort related to altered health status, and risk for injury related to seizure activity. I know we aren't supposed to do risk for nursing diagnoses, but meningitis can cause so many neurological deficits that the patient can be a danger to themselves without them knowing it. Injuries could lead to further complications and create unnecessary hurdles in the treatment plan.